Unamu. Hello, everyone, and a very warm welcome to you all. I'd like to just say it's lovely to be here doing this in the daylight. Last time I did one of these, it was definitely pitch black outside, so it's very nice to have some daylight to do this tonight. Thank you to all the members for joining, and welcome to members of the public or anyone who's joining one of these lectures for the very first time. My name's Del White, and I've been a governor here at CUH for 6 years. I was firstly a patient here and then became a member. And then I joined the Board of Governors in 2017. So CUH membership, our membership programme, it's free and it's open to anyone who's over 16 years old, patients, carers, members of the public. Anyone can become a member who has an interest in what we do here at the Trust. And we need members, we need members' opinions, and we need your input to help us to improve our hospitals. And in return, we offer NHS discounts, health-related events such as these Medicine for Members lectures. We do listening sessions and offer other experiences across the campus. And you can also vote in the governor elections. And we have some governor elections at the moment, and voting for the current governors will close on the 20th of May at 5 o'clock. And we've got around 8 vacancies, I think, at the moment. So I would just, before we start, like to encourage patients, public staff members, if you're on this session, if you can vote, if you haven't already, because it's important. Elected candidates are going to represent your views and influence important decisions at board level and champion local community needs. So, and all of this is going to help us to improve the future of Adam Brooks Hospital and the Rosie Hospital. For those of you who are not members yet, you can sign up tonight via our website, www.cuh.nhs.uk. And I think if you do tonight, you could probably still vote in the elections. So it's my great pleasure tonight to introduce the Medicine for Members topic and the speakers. And we're going to have a Q&A session at the end of the presentation. So tonight's Medicine for Members topic is all about traumatic brain injury, TBI, and our Cambridge HealthTech Research Centre, and all about the advancements in TBI injury management. So traumatic brain injury, it's one of the commonest causes of death under the age of 40 in high income countries. And I think that's quite a stunning statistic. I had no idea that was the case. And this lecture tonight is going to discuss some of the causes, the investigations and treatments, and how we can influence the outcomes of TBI. And we're going to hear tonight about the HealthTech Research Centre and how it's going to help to improve management of TBI and the lives of the patients and those other people affected, such as parents, carers, families. So we've got 2 speakers for you tonight. We've got Professor Peter Hutchinson, who's a neurosurgeon here at CUH, and he's the director of the Cambridge HealthTech Research Centre for Brain and Spine Injury. And we've got Alexis Ioannidis, who's a neurosurgeon also here at CUH, and he is co-director of the Cambridge HealthTech Research Centre. So Professor Hutch is a consultant neurosurgeon at Adam Brooks, and his subspecialist interest is in the management of neurotrauma, and specifically that of head and traumatic brain injury. He also has a research interest in acute brain injury and utilising monitoring technology to increase understanding of the pathophysiology of brain injury, and also in the investigation and treatment of concussion, which is a really important area. So Mr. Alexis Ioannidis, who is also an academic consultant neurosurgeon, and his subspecialty interest is in brain tumours and brain fluid disorders. Alexis is co-director of the HealthTech Research Centre in Brain Injury, and he was previously Deputy Director of the Brain Injury MedTech Cooperative, which I think was the precursor to what we currently have now. And they're going to talk to us a little bit about the centre tonight. And Alexa supports the development of new devices and technologies for improving quality of life of patients following any kind of brain injury. So this evening, we're going to ask you, if you could, to insert any questions you might have for our speakers into the chat at the top of your screen, in the chat box, which you'll see. And if you could maybe try and do that through the session as the speakers are presenting, then we can start the questions as soon as the presentations have finished. And also it means you don't forget your question. If we don't get through all the questions tonight, we'll try to answer those. We'll get back to you. We've got your email addresses. And if you like, you can post the questions directly to the speakers. So what I'm going to do now is pass over to Professor Hutch to kick things off, and then I'll come back to you when we start the Q&A session.
Great, thank you very much, Namu and Adele, for the invitation to speak to members, and welcome everybody to the virtual presentation. We're going to do this in two parts, as Adele said. I'm going to talk about head and traumatic brain injury. I'm Peter Hutchinson, Professor of Neurosurgery at the university and consultant here, and then my colleague Alexis is going to talk about this really exciting new centre that we've just kicked off in Cambridge. So neurotrauma, traumatic brain injury or head injury, is a journey for a patient from the scene of an incident through hospital care, so emergency department. Some patients require surgery, intensive care unit, but the goal is rehabilitation and getting these patients home. And as Adele said, TBI is the commonest cause of death under the age of 40, but what is of great concern is the morbidity or disability in many of the survivors from this condition, and that's what we're trying to address. So what are the causes of traumatic brain injury? They fall into four categories: road traffic collisions, falls, assaults, and then sporting injuries. Road traffic collisions are often a severe cause of injury, as are some falls. But then the sporting injuries are slightly different in that these tend to provoke a milder form of brain injury called concussion. In terms of the management of this condition in the Eastern region, Adam Brooks holds the East of England Major Neurotrauma Surgical Centre. So that's the major trauma network, and all the patients with severe injury are transferred directly to Cambridge if they're within 45 minutes to an hour. Beyond that, they will be taken to the nearest hospital to be stabilised. So our catchment for traumatic brain injury is around 5.4 million people across 6 counties. We cover 20 other hospitals. And within the region, this is a common condition, about 100,000 patients per annum, 10,000 admissions. The way to diagnose these injuries is through scanning. So this is a CT scan, and patients with severe injury, broadly speaking, have two types of scan. They may have a blood clot that you can see on this scan here. The white is the bone, inside is the dark area of the brain, and this is a blood clot. This requires urgent brain surgery to remove it. But some patients don't have a blood clot, but the brain is generally diffusely swollen, and the problem is that the brain is swelling within the tight confines of the skull. So we know after injury, the brain, like any other part of the body, will swell, but because the brain is confined within the skull, this ICP, this intracranial pressure, the pressure within the brain increases, and that affects the blood supply to the brain, the amount of oxygen to the brain. And if it's not treated, energy failure and cells will die, which provokes more swelling. So this cycle is what we're trying to treat. We measure the pressure in the brain by making a very fine hole in the skull. So these patients are unconscious. They're on life support on the intensive care unit. We make a very fine twist drill into the skull and then insert these pressure monitor probes. And we have some idea of what normal and abnormal brain pressure is. Normal is around what we call 10 millimeters of mercury. Above 20 is abnormal. But what's happened recently, and part of this has been driven through the HealthTech Research Centre and its predecessors, is there's now a whole host of different probes that we can insert into the brain to measure various parameters, including the pressure, how much oxygen the brain is getting, and the brain chemistry. And that includes how much glucose the brain is receiving. Glucose is a really important substance for metabolism of the brain. So we developed this device to insert these monitors. These are really sophisticated new technologies. But what's interesting is some of the technology we use is really old. So look, these are the neurosurgical instruments that were used in the Middle Ages, and these are instruments that we still use today. And you can see some of the similarities there. So the modern management of these patients is to insert the device that we designed through the skull, and then we place these monitoring probes of pressure, oxygen, and chemistry glucose monitors. And these measuring these parameters helps us guide the management of the patients. And there's various techniques that we can use to try and control brain pressure and swelling. We can nurse the patient's head up. We can sometimes place tubes into the fluid spaces in the drain to drain some of the brain fluid. Cooling is effective in some patients. And then there's a whole armamentarium of drugs that we can use to sedate the patient. We can increase the blood pressure to help encourage blood flow into the brain. Sometimes, despite that, the brain pressure remains really high and all our medical treatment is failing. The brain is very swollen, it's compressed in the skull, the pressure is going up. So we've developed this concept of releasing the pressure by removing a large piece of the skull of the patient, a neurosurgical operation, and then we put the scalp back over the brain. Why do we do that? Because it opens that box and it gives the brain somewhere to swell to under the scalp. And then, of course, further down the line, we need to put the skull back together. How do we do that? Sometimes we replace the patient's own bone that we've stored within the freezer, or sometimes we place the bone within the patient's own abdomen, the stomach, in order to keep it clean and sterile. But what we tend to do now is use synthetic materials as a replacement for the bone. So this is called plastic polyether ether ketone. What we tend to use now is titanium. This operation of bone removal to treat brain swelling is called decompressive craniectomy. And we performed a large clinical trial of decompressive craniectomy to show whether this operation would improve life and survival. And when we did that, we showed that if you took 100 patients and underwent this experimental procedure, decompressive craniectomy, you saved 21 more patients. What's important is about quality of survival, and about 2/3 of these patients have what we would regard as a good outcome, independent at home or outside the home. But some of the patients following the surgery were dependent, and we're doing further investigations to try and work out how we can improve recovery for those patients. I think what's really important is that historically we've focused on this condition in the United Kingdom, but actually about 90% of head injuries occur in low and middle income countries, including parts of Asia, South America, and sub-Saharan Africa. In order to try and address this problem, as well as the HealthTech Centre that Alexis is going to talk about, we run a global health group addressing the issue in particularly sub-Saharan Africa and India. And this is a slide to remind us of the importance of this condition. This is the world upside down, or my colleagues in Cape Town say this is actually how we should look at the world. But what is really striking is that trauma is a major, major cause of death. Trauma causes 11,000 deaths per day on the planet, and about half of those are due to a head and traumatic brain injury, and about 90% of them are occurring in low and middle income countries. And this is not about fancy neurosurgery. This is about simple measures, particularly related to road traffic accidents. This gentleman on the motorcycle is Lawrence of Arabia. He died in 1934, and that led Hugh Cairns, a neurosurgeon in Oxford, to develop helmets during the Second World War. But this is a photograph that I took in Chennai in India a few years ago, where the whole family is on the motorbike, but only dad is wearing the helmet. And we look at that, but then we think actually, if you come back home, you see many people around Cambridge and beyond who are cycling without a cycle helmet. So there is this campaign called Protect Your Melon, where we've undertaken a number of research studies looking at patients who've come in to the hospital following cycling accidents with and without cycle helmets. And there's no doubt that these studies show that cycle helmets are protective for all types of head injury, even high velocity accidents. So we very much from neurosurgery advocate the use of cycle helmets. And this is an example. This is a patient who was in the public press, and we launched a campaign after that called Better to Have a Broken Helmet Than a Fractured Skull. You look at her helmet, she made a really good recovery. It's dreadful to think what might have happened if she wasn't wearing this helmet. As part of the global work, we're developing new technologies, and Alexis is going to talk about new technologies in more detail. But this is a new scanner that's handheld that can be used to detect blood clots where CT is not available. We can use mobile phones to follow patients up, use text messaging. We can use ultrasound to help look at how the brain is functioning when other scans are not available. And then we're doing quite a lot of work in Africa, running neurotrauma courses and trying to improve the management of patients when full intensive care is not available. So finally, putting this all together, once the patient's discharged from hospital, we see them back in the neurotrauma clinic, neurosurgery. We have two amazing specialist nurses, Nicola Owen and Kirsty Grieve, who help us manage these patients. Rehabilitation consultants, Dr. Anwar and our colleague Harry Mee, neuropsychology. But what we've recently started is a specific sports concussion clinic. So we now have a clinic dedicated to managing patients with sports concussion. And we're working with the UK government, the Department of Culture, Media and Sport, Department of Health and Social Care on these concussion guidelines for non-elite grassroots sport. And then with my colleague Naomi Deaking, we have an interest in motorsport. So we're developing the concussion protocols for safe return from all sorts of sports, specifically motorsport, but also rugby and soccer. I'd just like to acknowledge that this work has been undertaken by many people, not least the patients who've participated in our research in Cambridge and their families, collaborating clinicians and research staff, and many of the funders, including the NIHR, the National Institute for Health and Care Research that Alexis is going to talk about, many colleagues in neurosurgery in Cambridge and beyond. And finally, I'd like to invite you all to this conference. This is a scientific medical conference called Neurotrauma 2024. It is being held in Cambridge from the 31st of August to the 5th of September. But this includes, as well as the neurosurgical talks, a public engagement event. And we have a number of people who are interested in sports concussion. We have a Paralympic cyclist who is injured. We have the daughter of Jeff Astle, Dawn Astle, and Jeff was injured through repetitive heading of the football. So you'd all be very welcome to register for this public engagement event, and that will be held in the Corn Exchange, but we can distribute further details. So that's all I wanted to say, and I'm now going to pass on to my colleague Alexis, who's going to talk about this really exciting new centre that we're developing in Cambridge.
Right. Thank you much. And thank you everybody for coming in to listen to some of our work. I'm just going to set up my screen. Right. So the second part of this talk is really saying, right, well, we know head injury is a problem, and we know that there's some groundbreaking research that is happening to take that further. But there's still a lot of work to do. And how do we really upscale this to involve more people, more patients, more solution providers to make things happen quickly? And of course, we learned some very positive and valuable lessons with the pandemic as well with this. So my talk is really around three parts and just focusing on why do we need a new center and why do we need to have a special approach for health technology in brain injury. So first of all, why do you need to treat brain injury differently as opposed to just have it as part of a wider healthcare center? what kind of things and how can we make the adoption of technology work better, and what kind of activities would one need to do? And then ending really by just looking at some examples of the kinds of technologies that we've supported in the past and also working at the moment to deliver into the future. So this is really just putting things in context from what you've heard earlier. And this is really putting some numbers. This was from a report which is now 6 years old, and it was called Time for Change. It was an all-parliamentary group in brain injury. They identified a number of areas where brain injury had a significant impact. And this infographic just illustrates some of the issue. So at the top, you can see the sheer number of patients who are living with disability. As you can see, these are UK figures. And it's not just numbers, but it does have a wider impact in society, not least economic impact, in that costs of healthcare, costs of lost, problems with returning to work, quality of life, family relationships. And if you look there, and I suspect now this figure is probably higher, it was estimated that all this problem could work out to about 10% of the total NHS budget. So really, this is something that does count, not just because of just patient quality of life, but also because it does impact on the wider UK society and the economy. So why is brain injury different? And I think there's one aspect that is very different from other conditions. And one injury on one patient is very different from one individual to the next. And that's because each part of the brain does a very specific function. And if you have a road traffic collision or even other conditions, I'll talk about later, the effect can be completely different depending on which part of the brain is affected. So it's much more unique. Now, why is this a problem? Now, if you think of solutions which are there to address a specific patient need, it means that you have a lot more individual needs. So if you're a solution provider for a company working on some big technology, some of them may not be big money spinners. So you have less of an incentive to develop solutions that can help a specific need, because the number of patients with that need may not be very big. So that's one challenge. The second one is head injury is not often visible and the needs are not often reported. And a lot of patients will live with a disability or problems. Families will live with looking after people with head injuries and not really speak up. So that means knowing about what the problems are and evaluating the right solution in the right individual or family is not straightforward. So these are two barriers that we need to have a specific approach for head injury, which is very different from other conditions. And when we talk about brain injury, if you look at that top thing, that it's the brain location, it's not just head injury which can cause that. So in a way, whether you have a brain bleed, whether you have a tumor that you've had surgery for, whether you've had an infection, or an inflammatory disease where the immune system turns on itself, if it affects the same location, you can get the same problems irrespective of the disease. So actually, when we talk about brain injury, you're dealing with an even bigger problem that these figures would suggest. So really the way we've approached brain injury is saying, actually, if the brain suffers an injury from any cause, the problems are similar, and the approach to deal with those problems ought to be similar as well. So then how do you support this? How do you support new technology to help patients? Because you've heard, some of the groundbreaking research that's been done in Cambridge and other places, but what about the sort of bigger picture? And this is something that a program that was started by the NIHR, which you've heard from Adele. And really, the NIHR is the research arm of the NHS. They fund a lot of research in making a difference to how we practice medicine and making a difference to patients' lives. So it started off with a program about 12 years ago called a Health Technology Cooperative. And they funded a number of centers across the country, each one looking at a particular problem. And we were involved in the brain injury health technology cooperative. As you can see, those are some pictures from some time ago, looking slightly younger in some of our team members. And this has evolved. So after 5 years, the program was expanded by the NIHR to what's called the MedTech Cooperative. And as of this year, it's been expanded even more with a bigger budget and a more ambitious mission to call it a HealthTech Research Centre. Now you see this complicated figure here, and this is just look at the top, say, how do you take a promising idea or a solution into being used in everyday clinical practice? And all these little boxes are individual organizations that sit along this pathway. And by this pathway, you've got the invention on the left. You need to work out if it works and does it do what we claim it's doing. Then saying, can be taken up by the health service? Is it affordable? Is it workable? And then diffusion at the end of saying, well, would more in hospitals, community practices, patients at home be able to take it up? And as you can see, there's quite a lot of boxes there. And the health technology cooperatives filled a very small space. They said, well, that's all very complicated. How do you work with all these people? Well, the good news is, over the years, this picture has been simplified. So as I said, the HealthTech research mission is actually more ambitious. And you can see here that this is really spanning the whole pathway from an early concept and invention all the way to making something ready to be bought by the NHS, providers outside the NHS, outside the UK, patients, carers, and just looking at this bigger picture. So we've actually got quite a lot more to do than when we first started doing this work. And that's, again, working with some other areas, particularly around research trials, I can see at the bottom, and also the more early stage biomedical research centers are really looking at this, early aspect of molecular technology, for example. So that's the sort of approach at the national scene. So if we go back to brain injury, and I said we've talked about the specific challenges of brain injury. How have we done it so far, and how do you want to do it over the next 5 years? So this is the Meta Cooperative, and this was our approach there. Just to recap, this was the last 5 years. And we broke the pathway into something very similar to what you heard from Professor Hutchinson. You need to think of prevention. You need to think of what happens when the patient is in acute care, be that in critical care or in a hospital setting. You need to think about working out who will do well, who will not, and how do you best support each group of patients. Think about recovery and rehabilitation, and just think of longer term reintegration back to normal life as well as possible. And the approach you developed was the 3 Fs: find, facilitate, and foster. And find, as you can see, that these are some figures from the last 5 years. How do we know what's relevant, especially in these underrepresented groups, people who don't express the problems with, their loved one head injury, or patients have a particular struggle? So we did a lot of work around working with patients and charities and professionals to work out what are the unmet needs that we don't know about. Then knowing that, saying, well, okay, which projects have a good promise, or which ones do they need a bit of a push to actually be supported by more than just us? So we set up what was called a seed corn competition, up to £10,000 to promising ideas, just to give them that first step onto the ladder of developing their solution. And this was extremely successful, and we were able to support a lot of these innovations into wider scale funding applications by the NIHR and other funding organizations. And then the fostering was really just trying to develop the broader environment around innovators, academics in universities, NHS clinicians, patients, charity groups, to take things that had a promise of working with some early evidence and take that forward. So this is what I've done in the last 5 years. And how do we take that further? I said more ambitious. Now, this is a busy slide, so obviously the key points are to the right, but I'll just talk a bit about these issues. And if we think about what we need to know before we drive a solution forward, I mentioned unmet need before, and that's very important. What do we need? What are the problems that have not been addressed? And that's not always obvious. But in addition to that, there's 2 other questions, because there's lots of people who might have a solution. And so we really need to know what is out there that might work for us. And sometimes the solutions might be in a completely different field, which is not related to brain injury. So a lot of our work is really working with other solution providers, companies, charities, and find out what is out there that might be adapted. And then, of course, is how do you know that this could work rather than just investing a lot up front? And so that's the other bit of who do you ask for advice? So as part of the scoping element or the identify part of our work is identifying all the experts, not just in Cambridge, who can give us the most correct, accurate, honest opinion on what will work. And as I said, because head injury has so many specific problems, you need a lot of people with the expertise to guide us in that. And this is an important first step. Now, the second bit, the evaluate, is really the biggest part of the HRC program's work, so the HealthTech Research Centre's work. And that asks the broader question of, does a solution that we think might work, does it actually work in the right patient group? And is the effect that it delivers worthwhile? Now, again, there's lots of individual bits. As you can see, this is a complex area, and there's lots of individual questions that we need to ask. But how do you make this more structured and in a way that can actually work in a more straightforward way? Well, we are creating this technology evaluation program where the HealthTech Research Centre, working with all its experts, is able to take something that has some good, promising evidence and just work through and develop the studies, as you've heard some of the studies around, say, for example, decompressive craniectomy. So what studies do you need to prove that this solution actually makes a difference before we then start saying, is it worthwhile taking it up wider within the NHS and beyond? And so a lot of our work is looking at developing these studies. And I'll talk about some examples in the last part of the talk. And the third bit is, right, we've shown something works, but can it really work in how things work at the moment? And is it affordable? And again, this, as you hear with the budget constraints and all the other problems with the economy, this is an important consideration. And a lot of innovations are what we call the NIHR calls the valley of death in particular, is that we know they work, we know they have a role, but they don't make it. And then a lot of companies or solutions essentially go bust because of that. So it's really saying, we've shown this, can we work with the wider partners to actually say, well, can you consider taking it up and making a difference? So again, this is really finishing off this pathway into the wider world beyond just research. So other part of the house, who do you work with? I said, you need lots of experts, and you need lots of experts across different organizations and across different sectors. So the HealthTech Research Centre, whilst it's based in Cambridge, is actually a partnership across people across the UK. So we work with 6 out of the NHS trusts, as well as 4 universities which form the core partnership. You can see them there. We have a number of key collaborators outside academia and the NHS, which include small companies, large companies, charities, and other government-supported organizations. And as I said, the wider infrastructure or the wider number of organizations supported by the NIHR, as you can see, the research arm of the NHS have specific organizations that can help us with that work. And also other organizations which, for example, evaluate how effective interventions are and whether it's safe to do that. So that's the sort of, and then you can see here, this is across the UK. So the last bit of the talk is, well, this is what we want to do, and this is with who are going to do it. So really the last bit is, what kind of technology? So, well, that's all well and good. Can you give me some examples? And the work is really divided into 5 themes. Now, 3 of them correspond to the bits that you can make a difference in head injury. As you can see, those 3 on the left. So first of all is preventing an injury from happening in the first place, reducing the damage that it can cause, as we call neuroprotection, and you heard some examples around, pressure monitoring that you've heard in the critical care unit. And then if it does happen, how do you support recovery of a patient and their family to return back to a new balance, a normal life as much as possible? The other 2 themes are really dealing with the specific challenges around diagnostic tests and also the specific challenges at the extremes of age. For example, neonates, so young babies, and what happens if they have a head injury, and also at the other end extreme, in the elderly. So I'll just give you some examples, which I'm sure we can, discuss as part of the Q&A. So you've heard some things around concussion and the concussion clinic and the work around that. So, for example, just looking at some projects that we've supported, the SCORES project is something that we've supported, and this is looking at cognitive assessment over time in professional athletes, and particularly footballers. And that's really trying to ask the question, well, you heard of some interesting case studies that, oh, yes, people who have headed the ball may get dementia, but this is looking in a more structured way and saying, can we measure this over time and just get a very objective way of measuring this? And you can see that from the timeline. You need to do it over a long time to get robust data. And this is something that's been going on and is now in phase 3 of this project. And at the other end is, well, what about the solutions you have? So, for example, we've supported through one of our seed corn competitions that I've mentioned. We're working with a company called Resin. They have protective headgear. And they're asking a question that we've supported of, if you wear a specific helmet, does it change your behavior? And then doing that specific assessment in women's rugby. So again, there's all these little details that can help us understand how we apply these preventative approaches. And altogether, they fit into the broader picture. If we move on to neuroprotective strategies, again, this is largely in the accident and emergency department, even in the ambulance before, in the critical care. I'll give you two particular examples. One is a non-invasive device as opposed to putting a wire in. If you put a non-invasive device, can you detect a blood clot in somebody who has had a head injury early on? So, for example, this could be used in the ambulance or as soon as the patient arrives into A&E before they've had the chance for a CT scan. So this could mean that you prioritize patients that have been flagged as, more, prone to deterioration and prioritize them before you get, the sequelae of injury. On the other side, you've heard about cooling as a strategy. The problem of cooling is that a lot of the approaches we use now cool the whole body. And whilst we know that cooling is good for the brain in some conditions like cardiac arrest, the studies which have been done in brain injury have shown that it's overall not a good idea, but likely because of all the negative effects on the rest of the body, particularly the lungs. So what we've worked with a company called Neuron Guard is to develop a collar that just cools the blood going to the head. So we did the first study on 10 patients showing that this works. It does cool the head, and we're looking now for further studies to show that it could actually make a difference to outcome down the line. And then what about the third bit, the longer term recovery into rehabilitation? And again, this shows why the specifics of a brain injury matter. This solution we worked with a company called Animorph, and which has been working with the University of East Anglia and Norwich, is for looking at a specific problem that some patients have with brain injury, which is called neglect. And that's where you're not aware of one side of the body or one side of sensory. So that includes vision, touch, hearing, perception. And that can be very debilitating, and it can really stop your recovery. And a lot of studies have shown that. But the problem is, how do you get therapists to support that? Or how long do patients need to be in hospital? So the solution that we have supported is an app that can work on a tablet and hence can be delivered at home. And what it does is try to use a technology that's been shown to work. So if you keep having these dots moving on a screen towards the side that you're not aware of, if you keep doing that, your brain learns to recognize more effectively, to recognize that side. So so we've worked with this to develop a trial that, you can do 2 sessions a day for over a period of 5 weeks. Could that mean you need less therapy input in hospital? Or could it even mean that patients could go home and do this at home rather than being in hospital? So again, the cost impact within within rehabilitation. What about at home? So we've worked with 2 companies looking at digital rehabilitation and support at home. You've heard the problem of concussion earlier. So this is an initiative that, again, we supported a lot of the early work to generate the evidence. And this is a digital program to support recovery from concussion in specific ways that can be done in the home, or for people with more severe brain problems. So this is another app that we've worked with and the company to just give support to specific problems, working with both the patient and the family to help with coping with everyday tasks. So as you can see, different ends of the spectrum from mild to more severe head injury in this recovery. And the last thing, two more things to say. One is around bringing things together within a broader pathway of care, and also the fact that not all brain injury because of head injury. This is a project that I've worked on. This is a project looking at a condition called normal pressure hydrocephalus, which is also known as a form of reversible dementia. And the problems we have with that is that you have problems with walking, problems with cognition, thinking and memory, and also problems with your bladder control. And whilst we had diagnostic tests that can be used, high-end science looking at brain pressures, this project really looked at putting everything together. And really, can this diagnostic test work as part of a pathway? Can we engage with clinicians, particularly in the community like GPs, to refer patients they think might have this condition? And then can we deliver this cost effectively? So we set up a clinic, information leaflets, a media campaign. So we were able to increase our referrals by threefold and also decrease the amount of time it takes to treat, as well as the number of bed days it takes to treat. So now we have a much more efficient process. And this, of course, has been taken up by the NHS into a new type of care pathway. And last, but certainly not least, is how to engage with patients, carers, so working beyond professionals. So two ways. I mean, we set up a database called Right. So any patient, carer, or professional can say, I'm interested in learning more about brain injury. I'm interested in being involved in these studies. I'm interested in being able to give them feedback on how these studies should be defined, or feedback on what are the unmet needs that I have experience of. So this Right data, this has been going on for 5 years. It keeps on expanding. And really, as part of that, for example, we've set up an outreach program where when we want to get patients and carers to evaluate a solution that comes our way, we arrange a session, they give feedback, which can then be taken on board, either when refining the design of a solution or potentially designing the next study. So again, this is part of all our programs of work, not just the evaluation phase, but this is a very important part, which is not really being done as well as it could across a lot of research. So just to summarize, the three bits I said at the beginning: why is a health tech research in brain injury relevant? Because brain injury has specific needs. How do you make this happen? We need to know what's out there and what is needed. We need to have good quality evidence that will then support wider adoption. And then, of course, what kind of technology? I'm hoping I've given you a flavor of some of the very specific problems that we've tried to address with some of the work to date and some of the work we're addressing. And of course, just to finish off, I think it's worth acknowledging, the many, many people who have supported us in this process and continue to support us. We've had a number of experts who have worked as our theme leads, but also core to the program. Mita Brambert, who's been our senior program manager for the last 10 years, is also senior program manager moving forward, and also as part of the MIC, Jackie Green, who worked as the project manager, and particularly her work with the outreach program. And with that, I'd also like to thank you for your attention.
Thank you very much, Alexis. Thank you, Professor Hutchinson. Wow, we've covered a lot of ground, I think, in a very short space of time there. I'm sure there's a lot more that you could have put into that, but thank you for compressing some of that for us all to hear this evening. There's been I'd just like to say that just looking at those early pictures you put up of the sort of the tools that we used to treat brain injury many years ago compared to some of the high-tech solutions you've outlined, what a journey. So thank you for that. I would like to just open the Q&A session now and invite you to submit any questions you have to our speakers on what you've heard this evening through the chat box. Namu, I can't see any at the moment, but I'm not sure if I'm sort of getting everything at the moment in the chat box. So whilst we're just waiting for
Sorry.
people to...
There is one, yeah.
Sorry, Adele, there is one. So there's one from Roy Swain, which says, do some cardiac arrest sufferers constitute a proportion of the TBI statistics?
So maybe Roy, that's a great question. Thank you for asking it. The TBI statistics in their purest form, which is 1 million patients coming with a head injury to an emergency department here in the UK, do not include cardiac arrest sufferers. So cardiac arrest, I think, is different. That's a primary event that affects the heart. But having said that, severe traumatic brain injury can result in cardiac arrest for some patients, and also cardiac arrest without traumatic brain injury for a prolonged period of time can lead to impairment of oxygen to the brain and another form of brain injury, acquired brain injury, what we call hypoxic brain injury, when there's a lack of oxygen supply. So there is a relationship between cardiac arrest and TBI, but it's not included in the pure TBI statistics.
Thank you so much.
Yes, I can see the chats now. So they started to come in through my feed. And we've got one here from David. What advances do you believe will be in place 20 years from now that would change the amount of care for those patients and their clinical outcomes?
I would say that, well, being slightly provocative, that this is a very fast-moving field. And from our experience, when we start, looking 5 years from now ago and where we are now, a lot of innovations we weren't even aware of at the time. So I would like to say that we need to be adaptable and we need to think on shorter timelines to make things, apply change. So I would say that it would be very difficult to know in 20 years where we would be, because ideally we would have very good neuroprotective strategies and also very good support for whatever head injury you have on how you can get back. But I would like to think, we should be working in 5-year times rather than 20 years.
Yeah. And there's another one about accessing right.
Oh, I will put a link. So 2 things. One is around our patient engagement. There is an email address which I'm putting in the chat, and I will also put the address for right in a moment.
Thank you. I've got a question actually. You talked a little bit about new technology in the sporting community, particularly on sporting concussion. And particularly, I know a lot of what you're doing is, you need funding for it. Has the sporting community been forthcoming in terms of, because they've got lots of money basically, has that happened for you? Is that an area that you're hopeful more will be able to come from the sporting community?
Yeah, I think we're working very closely with the sporting community, particularly the governing bodies. So I sit on the independent concussion panel of the Rugby Football Union, and we have a close relationship with the motorsport community and Silverstone. So I think the most important thing is that there's a much greater awareness of the problem, and the sporting bodies are very committed to try and reduce the effects of concussion and get safe return through, and a lot of that is through technologies. But there is quite a lot of concern in government at the moment through the Department of Culture, Media and Sport, DHSC, about how we're going to tackle that problem. And there are some more research opportunities coming through.
Mm-hmm. So that's all going in the right direction then, hopefully.
I think that, it's going in the right direction. It could always go quicker. And as I said, I think the professional sporting bodies generally have good mechanisms in place, but what we're really concerned about is grassroots sport. So schools, and particularly university sport, and access to good quality care, which is our incentive for setting up the specialist sports concussion clinic in Cambridge. And we see a number of university students, and we're seeing an increasing number of children in that clinic.
Yeah. Mm-hmm. Yeah, my son had concussion from a rugby injury, so you know, I know a little bit about that. Yes,
I think there's a balance between making sport safe, but what we don't want to do is stop people playing sport, because it's really important for the health of the nation, and it's a really important, you know, activity for people. So we're just there to try and make it safe.
Yeah. So one of the things you talked about, I think, Alexis, was around almost a business case you talked about for supporting innovation. So some of the innovations that potentially could help, it's almost as if you have to present, or there has to be a business case for it. Can you tell us a little more about that? That was part of I think, the last few slides of your presentation.
Yeah. And thanks, Ada. I mean, and as I mentioned, a lot of things that could work very well don't make it to being sustainable. And this is a big problem. And the take-home message that we hear from other funding bodies, the NHS, NICE, is that you need to start that process early. And what I mean by that is you need to say, how would this work? In which point in the pathway? What kind of impact do you need to achieve to make it worthwhile compared to what we're doing now? And I think there's a large area of work around budget impact analysis, health economics, that needs to happen in parallel with developing and refining the solution, because the two can interact. So, for example, it may be that you have something that works, but it could work in a slightly different way, which is more cost effective. And by that, I mean, well, you might have something that works for measuring brain pressure without having a wire. Now, of course, that might have been developed for the ICU, but a lot of the time, if it's more expensive and you end up putting a wire for other reasons, then it might not have such a strong case. However, there are other reasons we want to measure brain pressure in people who have brain pressure disorders. And that will make a huge difference to be able to do non-invasively, because the patient doesn't need to come to hospital. They don't need to go into theatre to have a wire inserted, and they don't need to stay in hospital for 2 days to measure their pressure. So, for example, you can see how sometimes asking the economic question means you change the direction of the solution to make it sustainable. And the real focus is to try and do that early and in parallel to make sure that you ultimately succeed into the real world.
Could I just pick up one of the questions from the chat, because it's a really important question. It's from Kate Kendrick, and it's about raising the profile of therapists. So I think what's often forgotten is that the management of these patients is multidisciplinary. So it involves a lot of specialist consultants, but also nursing staff. Already talked about our specialist nurses. But, you know, the role of the occupational therapist, the physiotherapist, speech and language therapy, and neuropsychology is absolutely paramount. And I think we do need to do more to raise the profile. And a lot of that can be done by getting therapists engaged in research. And I know the NIHR, in terms of career development, are really trying to focus on allied medical professionals and therapists. So that's a great question from Kate, and something that we need to do more on. Thank you.
Thank you. I think we've also got one regarding TBI in the elderly, and dementia, delirium, and infectious causes of fall and head injury. Who would like to talk about that one?
Awesome.
There's some relevant to your revert, yeah.
Yeah, so if you think of injury, it does pose particular challenges. The fact that, you know, as the question says, there are multiple comorbidities, and you also need multi-specialist as well as multidisciplinary input. So I think that we've worked, I can give two examples, one in sort of elective care and one in sort of non-elective emergency care. So as I mentioned, normal pressure hydrocephalus is a form of injury that is potentially reversible. So again, how do you approach that in terms of differentiating from other causes, Well, you need to have good diagnostic tests, and they need to work within the pathway, and that's the kind of work we've done. If you look at a different condition, which is more acute, is something called chronic subdural hematoma, which you could also call it a reversible form of stroke. It's when you have blood between the brain and the skull, and you can drain it with a smallish hole, so it's not as invasive as a large portion of the skull coming off. And there again, we've done a lot of work around the pathway of that, involving very different professionals, both within a neurosurgical center, which can treat it surgically, and also centers within the whole region that would look after patients who could have this condition, working with other specialties, including elderly medicine, working with therapists, and really just trying to set up a pathway to recognize the problems and act on them. And again, it's very multifaceted. So for example, in this project that's been driven by particularly 2 trainees who really engage everyone together, you have to do with establishing guidelines, and we've done work around, creating a set of guidelines, showing the problem both in terms of problems of the pathway and then evaluating the outcomes. So it's not one solution fits all, but you really need to ask the problem and think of the particular challenges in elderly care, and then get the right people together to come up with solutions, then act on them. And yes, that's a very big focus, particularly in the broader NHS.
Thank you. Thanks. We have an earlier question here about from Deborah. What do you think mostly affects those who don't return to normal life post TBI? What sort of specific comorbidities do you see?
I think the comorbidities can be divided into 3, and the first is physical. So physical symptoms: headaches, visual impairment, dizziness, fatigue. The second is psychological or cognitive, so memory impairment, impairment of high executive function, so planning and thought processing, which can be a real challenge. And thirdly, behavioural and personality change, so mood disturbance and often frustration and aggression in some patients. Often, particularly the mild patients, make a really good physical recovery, but it's often quite subtle in terms of their cognition and behaviour that becomes the rate limiting step to return to normality.
Thanks. Yeah, we've got another question about rehab in acute care undertaken, and about how you evaluate it.
The short answer is
Okay, that's all right. So select technical issue. The short answer is it's challenging, because it is delivered across in parallel with acute care. You might need to do further medical interventions, surgical interventions, and also the provision is quite variable. So, there has been a lot of work in this area. So, for example, in trauma, the concept of rapid access acute rehab is now reasonably well established. But there is also an issue of access. And some of our rehab collaborators have done some work in looking at the impact of, for example, RAR in its entirety. But it is, unfortunately, if you look at the scale of the problem and how much is being covered, there is still a mismatch. And for example, as I said, unmet need, there's a lot of work now on gap analysis to say, well, these are the requirements for rehab. How many people need it? How many people get it? And needs versus get is actually a very large area of discussion at the moment.
Thank you. We've got a couple of questions about the handheld scanner. Professor Hutchinson, perhaps you could just tell us a little more about that, please.
Yeah, so I've put, I don't know if everybody can see the chat, but the website is infrascanner.com, and that's been developed because CT scanning we take for granted in the UK, but many parts of the world do not have CT or access to CT. So that's a device that uses a special type of near infrared light frequency to penetrate through the scalp and the skull and can detect blood clots within 3 centimeters of the surface of the brain. So that's something we're pioneering in Colombia and Guatemala at the moment.
Okay, thank you for that. Thanks. Okay, thank you so much. I'm just looking at the time here. We've got pretty much through most of the questions here. I think just forget. Apologies. The questions feed on my screen was quite slow coming through, so it was a little bit random responding to you. But I think we've covered most of the ones here. So thank you very much. And I think that we need to close the conversation now. So I'd just like to say thank you all for joining us this evening, and thank you for our two speakers. It's been absolutely fascinating to hear about this topic and to hear about the extraordinary work that you are doing. To everyone who's joined us this evening, we would be really grateful if you could complete our short survey. And Namu's put the survey link in the chat box, which should be hopefully at the top of your screen, even if it's not at the top of mine. The recording of this webinar is going to be posted on the CUH website. And also we put it onto YouTube, and hopefully that will be by the end of next week. So thank you very much, all of you. It's been a great evening, and look forward to seeing you at more of our Medicine for Members events. Thank you all. Bye.
Thank you.
Thank
Bye.
you.
Bye.